My name is Leah Jolly, and I am here to talk to you about some basics of physics, knobology, hemodynamics. We could really do a whole webinar series on just this topic, so I'm going to try and do my best to lay a foundation for what the other presenters are going to be talking about later this week. Just a little about myself. I am the program director for vascular technology at the Oregon Institute of Technology. That's also known as OIT or Oregon Tech. So let's get started. So just a few objectives for this. We're going to talk about which ultrasound transducers to select for common vascular exams, how to correctly orient your image for a vascular study, hopefully at least get you started on how to interpret flow direction on color and pulse wave Dopplers if you're not already comfortable with that. Understand physiologic effects on hemodynamics, some of them normal, some abnormal, and also begin to describe arterial and venous waveforms and hopefully get those consistent. As far as instrumentation goes, I'm only talking about the ultrasound machine. Today in exams, we do using ultrasound. In vascular, there are some places that do physiologic testing, which uses a completely different machine. I'm not going to cover that today, but we'll talk about B mode, color, and pulse wave Doppler. On ultrasound with vascular, we typically don't use continuous wave. So if you do echocardiography studies, they do a lot of with continuous wave, but we don't usually use that in vascular, at least during the imaging. Typical probes we're going to use, the one we use probably the most often is a mid-range frequency linear transducer. So on this image here, that would be this one on the left. It's usually around 7 megahertz, although the frequency range might change a little bit depending on the manufacturer. But this typical carotid upper and lower extremity exams, and usually with this, you're going to get sort of a square or rectangular shaped image. This particular picture I have here is showing with an extended field of view, which some probes do allow you to do that, but a lot of times they just come up as a rectangle. The low frequency curvilinear transducer on the right of this image would be used for more abdominal exams, or if you have maybe a larger patient that you need to scan through thick legs, thick calves, or even get really distal on the carotid artery, that curvilinear transducer is helpful for that. This phased array transducer in the middle that's typically used for cardiac imaging, we can use it in vascular, particularly for transcranial imaging. So looking at the brain and the circle of Willis. It can also be used for abdominal and peripheral exams, but it's not used as often just because it has such a small footprint. Usually we're going to go with one of the other probes. So first for B mode stands for brightness mode, also known as grayscale or 2D, two-dimensional imaging. So if you hear these terms, they're basically used interchangeably depending on who you're talking to. So B mode is this kind of black and white and gray image that we're looking at. We use this for soft tissue imaging, and also we want to see that the inside of the vessels are black when we're doing these studies. So we can see on this image here, this is the internal jugular vein right here. This is a common carotid artery. Internal jugular is nice and black. That's what we want to see, nice and dark. This common carotid has some fuzzy stuff in there. So we want to determine, is that pathology, or is it just that we need to adjust the machine a little bit and try and minimize that if at all possible? So some things we can adjust. Gain is going to increase or decrease the overall brightness of the image. So in this case, if we were trying to get rid of that fuzz, we would decrease the gain. We can also adjust TGCs or time gain controls, which adjust the line by line brightness horizontally. So it's basically individual strips of gain. Some machines also have lateral gain compensation, which allows you to adjust the brightness vertically. We don't use that a ton in vascular, but you might find some applications for that. Dynamic range is another thing that can be adjusted that basically just makes the image more or less contrasted. So you can make it more black and white, or you can give it more shades of gray. Typically, we want it somewhere in the middle where, again, vessels are black, but we can still see the different echo textures of the surrounding tissues. Other B mode adjustments we'll make. Depth is a big one that we adjust quite a bit with vascular. So we want to adjust it so that the vessel of interest is centered on the screen. And we can see in this image here, here's the vessel. This is a really tiny vessel, but we want it centered as much as possible right there. Focus is another thing we can adjust, although focus seems to be going away on a lot of the newer machines, but some of the older machines still have it. So this little circle right here is showing this arrow, and that's where the focus is located. So this is focusing the ultrasound beam to a specific area on the image. What we want to do is line this up either directly with the vessel of interest or just below it. And that typically is going to make the vessel appear clearer on the image. You'll also notice probably that there's a loss of contact. We have a signal dropout on this image. And this is because we were scanning an arm, and the arms tend to be smaller, kind of rounded, and to get the right image and the right shot of the vessel, sometimes you might lose contact with the skin on the probe. If we push down with this too much, this is a vein and it would collapse if we had contact with the skin here. So in this case, that image dropout is okay. In other instances, it might mean that you need more gel, and so then we could add some gel to the probe. Imaging planes, we typically use transverse and longitudinal. Some people use the term sagittal for longitudinal, but we are not always necessarily scanning vessels directly from midline. So that's why we tend to use longitudinal or long axis rather than the term sagittal. So you can see with transverse, we are looking at circular structures. So we're cutting through the vessels horizontally. And of course, in longitudinal or long axis, the vessel is elongated. When we're scanning in trans, we want the indicator on the probe to be towards the patient's right. So let me go back to this really quick. We have this little notch on the probe that's called the indicator. And typically in vascular exams, we want it to go to the patient's right when we're scanning in transverse. Also, looking at the screen, the top of the image is going to be the patient's skin or the transducer. That's where the probe is located. The left of our screen is going to be the patient's right side. Then the right of the screen is going to be the patient's left side. So it looks like we're facing them, as if we're going to shake their hand or something like that. And then the bottom of the screen is going to be deeper tissue that we're kind of ignoring at this point because the vessels are already centered on the screen. Then we go into long axis, and when we turn the probe, we want that indicator to go up towards the patient's head. And it doesn't matter if we're in a leg, an arm, the neck, it always goes towards the patient's head. So that means that the left side of the screen here is the patient's head, and the right side of the screen is down towards the patient's feet. With color Doppler is the next tool we're going to use. So we've assessed the vessel with B mode, looked for any pathologies that we can see there. We're going to turn on the color. So color displays the movement of blood as different colors, and we can adjust the settings to show which color we want it to show. It shows the general speed and direction of blood flow in real time. We don't measure the speed with color, but we can see where it's moving faster or slower as it's going through the vessel. Color is typically used to assist in tracking the course of vessels, especially if you're having a hard time seeing them in B mode. You can turn the color on and it'll help you follow them further. We can demonstrate flow abnormalities, such as what we're seeing in this image here, where we can see that there is a dark area of narrowing. Typically, we want the color to go to the edge of the vessel wall here. So we can see that there is a filling defect and there's likely plaque in this artery. We can also identify the greatest velocity shift for placement of the pulse wave Doppler sample volume. And to do that, we look for color aliasing, or sort of a rainbow mosaic pattern. So we can see a little bit of aliasing here where it's yellow. It's probably the most aliasing is right here in this area. We're just not seeing it on this image, but we're going to see some later on. Power Doppler is another tool we can use. It is more sensitive than color Doppler, but we don't use it all the time. It should be used in low flow states. So if you have a vessel that isn't getting much flow, or if you suspect that the vessel might be completely occluded or 100% obstructed, Power Doppler can help to see if there is any trickle of flow going through that vessel. So this is just a stenosis comparing color Doppler and Power Doppler, and you can see this narrowing on the color Doppler. You can see nice red color here, and then we get to the narrowed segment. And yes, lo and behold, color aliasing. So that rainbow color mosaic right here. And then we get beyond that area and we can see some red and some blue, and that's suggesting that there is some turbulent flow right there. It's kind of swirling around a little bit. We can also see that this artery is red and the vessel above is blue. This is the vein. So we can tell that the flow is going different directions in the artery and the vein. Compared to the Power Doppler, we can again see that narrowing very clearly in the artery. What we can't distinguish is the difference in flow direction with Power Doppler. There are some machines that offer bidirectional Power Doppler, in which case you could use it for that, but still not as much color aliasing where it would tell you directly which velocities are being seen in that area. Steering is really important. So your box, the color box matters. So position. If you're looking at vessels in transverse and you're trying to get color in trans, we recommend that you put the box straight up and down. So you want it to actually look like a square if you're looking at vessels in transverse. You might also have to tilt the probe just a little bit to get the color to show up. If you come straight down on a vessel and encounter it at 90 degrees, there is no Doppler shift. So you can't see any flow, or it'll kind of be swirling in different colors and you can't tell which direction it's going. So you might need to tilt your probe forward or backward just a little bit to be able to get that color to show up. In long axis, you want to steer the box in the same direction as the vessel. So in this case, we can see that this vessel is sloping from top left to bottom right, and we want to steer the box that same direction. So these side bars on the box steer also top left to bottom right. And so that helps us to know that we are accurately interpreting which way the flow is going. The size of the box also matters. We don't want to make the box as big as our whole screen because that slows down our frame rate. And then we can't keep up with how fast things are moving in real time. So we want to make the box smaller. And ideally, on a larger vessel, the box is about 2/3 the size of the vessel. So we've got 1/3 of tissue here, we've got 1/3 of vessel, and then we've got another 1/3 of tissue down below. So this box could probably be a little bit smaller. I'd probably move this up to here, but it's a pretty good size to get the flow going through there. Smaller vessel, you don't necessarily have to make the box really tiny. For example, if you're scanning in the forearms or in the calves on those vessels, but make it a decent size where you can still see the flow going through it. All right, color scale. The numbers on the color scale, so above and below, represent the mean velocity being detected in that area. So you want to set those numbers to the approximate normal mean velocity range for the examined vessel. So if you're scanning a carotid artery, we know that carotids are typically over 100 centimeters per second, but you might only want your color scale set closer to 50 so that you can pick up flow that's higher than that and you can pick up flow that is lower than that. A color mosaic pattern should not be seen unless there is a flow disturbance, and we can clearly see a flow disturbance right here. So good flow going through this proximal part of the vessel, but then we can definitely see a narrowed area with that color mosaic pattern. And then beyond that, all of this outside of the vessel wall, that's not actually blood, but there's so much turbulence happening in this area that it's vibrating the tissue outside of the vessel wall. So we're picking that up on the color Doppler. So just a little breakdown of the color scale again. Here is our mean velocity that's being detected on either side. If you move this baseline that's in the middle of the color, these numbers will change, and one will be higher and one will be lower. So typically in vascular, we just leave it as is. We don't usually adjust the baseline on the color. Flow direction, the top color is going to be moving towards the probe, so that's a positive Doppler shift. Bottom color is away from the transducer, or a negative Doppler shift. And you can even see on this scale here, there is a negative number on the bottom, positive number on the top. Of course, the color can be inverted, so we can switch it so that red is on top and blue is on the bottom. But in vascular, typically we want to show arteries as red flow and veins as blue flow. So if flow is moving in the correct direction, arteries should be red and veins should be blue. So here's just a practice example, and this is a popliteal artery. So we're behind the knee, and they're using the curvilinear transducer, but just so they can show this long segment collateral vessel. So this is a tiny little vessel that basically what's probably happening here is that the actual popliteal artery is occluded, and this collateral is providing flow around that. So we can see that this, even though there's some color mosaic pattern in there, it's mostly red. And if we look at the color scale over here, red is moving towards the transducer. So if we have our probe oriented correctly, this arterial flow is moving towards the feet. So that's the correct direction. In contrast, this is the popliteal vein, and you can see they've decreased the color scale quite a bit. So we've got quite a bit of bleeding outside of the vessel, but I believe that's because they were focused on this collateral and trying to show the flow in that. But flow is blue in this vein, and based on this color scale, that means it's moving away from the transducer. So in this direction, and that's the head over here. So flow is moving back towards the heart in this vein and going the correct way. All right, pulse wave Doppler, similar. So pulse wave and spectral Doppler are often used interchangeably. Continuous wave is also a form of spectral Doppler, but if you hear people say pulse wave or spectral Doppler or just Doppler period, they're talking about pulse wave. So it should always be taken in long axis. So if you are going to measure a velocity, must be done in long axis. We cannot do that accurately in transverse. Velocities are used to categorize disease. So we need that velocity measurement. And we also look at the waveforms. And I'll talk about waveform analysis in a little bit. But this is very, very low flow going through this artery. So that's only 2.2 centimeters per second. You can see that the velocity measurement was only 2.3. So there's just barely a trickle of flow going through this vessel. So things to consider with pulse wave, your sample volume or sample gate, which is this little equals sign right here in the middle of the Doppler beam, that should be placed in the center of the vessel. If you have a stenosis or some kind of pathology where the majority of flow is going kind of off to the side or it's taking a funny angle, then you want to place your sample volume in the flow jet. But for the most part, it usually goes right in the center of the vessel. The size of it should be approximately 1/3 the vessel diameter in larger vessels. However, there are exceptions if you're taking, for example, like a volume flow measurement where we need it to be the size of the whole vessel. But most of the time, you just want it centered in the vessel because that's where the fastest flow is going to be moving. In a small, tiny vessel, like a radial artery, it might take up the entire vessel, and that's okay. Angle matters. So ideally, we want our angles to be 60 degrees unless you cannot reasonably achieve it. So 60 degrees was chosen because it is easily achievable in most vessels because our vessels tend to run fairly parallel to the skin. So 60 degrees is used very commonly. And also your angle should be parallel to the vessel wall or that flow jet if you happen to have one of those. And I'll show you what these are in a minute. And then the steering is very similar to color. So you want to steer your Doppler beam right or left along with the vessel angulation. So your color box is steered one way, your pulse wave should be steered the same way as the vessel is leaning. It may require you to do a heel-toe maneuver with the transducer. So you might have to tilt your probe up or down a little bit to obtain proper alignment as well. And that can go a long way into getting parallel. And then you might also need to steer straight up and down if the vessel is tilted that way and a 0-degree angle is needed. Not many of those happen, few in the abdomen. Anterior tibial artery origin in the leg can be straight up and down sometimes, but for the most part, we can get 60 degrees in most vessels. So here's our sample volume or sample gate, this little equal sign right there. And then our angle is actually the angle of inclination in which this Doppler beam is encountering the vessel. So this little line right here matters, and that needs to be parallel to the vessel wall. Here's our baseline. We do adjust the pulse wave baseline quite a bit when we're scanning. So we want to make it so that the waveform fits entirely on the spectrum and it's not wrapping around. That's an artifact called aliasing if we let that happen. And we will also adjust the scale so that the waveform fits properly on the baseline. We don't want tiny little waveforms that we can't measure properly. We also don't want big, huge waveforms that are gonna, again, wrap around and alias. We can also see flow direction here. So you notice that this is a negative number on top of the baseline. That means flow is moving away from the transducer. So we match that with this negative number on the red. We have a negative Doppler shift, so flow is moving away from the probe and going towards the feet. So this is just demonstrating that heel and toe. Here's the toe where we're rocking the probe in one direction. And what that does is it puts this side of the transducer closer to the vessel and makes the vessel tilt. So we have this vessel nicely angled and we can achieve that 60-degree Doppler angle. We can also heel the probe, which means we push the other end of the probe into the patient's skin, and that makes the vessel tilt the other direction. So some vessels are already naturally tilted, others we have to make adjustments on our own. Okay. So the next part that is really important in vascular is analyzing the hemodynamics. So anybody can take pictures and follow a protocol, but this analysis and understanding how the blood is flowing is really what sets us apart from the picture takers. Okay, so just a little bit about vascular anatomy. Hope this is review for everybody, but of course we have the pump, the heart that is pumping blood to the rest of the system. The blood is taking all the oxygen and nutrients to the system and all the waste back. The arteries are the distribution vessels. So arteries take blood away from the heart. Then the regulatory vessels are the arterioles. These are really important. They're usually too small for us to scan, but these are actually what control how much blood gets to an area or doesn't. So they can dilate or constrict and control the amount of blood getting to each area to meet the demand for flow. Then we have the capillaries, where the exchange of oxygen and nutrients occurs. And then we get into the venules, where now the capillaries are coming back together before we get back into the venous circulation to get back to the heart. So another important thing to consider is when we describe where we are in a vessel, we talk about proximal and distal. Proximal in the circulatory system means closer to the heart. And it doesn't matter if we're talking about arteries or veins, proximal is close to the heart. Distal means further away from the heart. So if you're scanning a leg, for example, proximal is going to be up in the thigh near the abdomen. Distal is going to be down towards the toes. So the further you move away from the heart, the more distal you get. Blood and water flow similarly, and fluid, no matter what type it is, always takes the path of least resistance. So there is a lot of pressure happening through our bodies, and this is what helps the blood move through it. So blood flows from areas of high pressure to areas of low pressure. And it just happens that the left ventricle has the highest pressure in the body. So when it contracts, ventricle gets up to roughly 120 millimeters of mercury. And this pushes blood through the system. And you can see on this graph that as we get further through the system, the pressure decreases. And it keeps decreasing till we get to the vena cava. And ultimately, the right atrium has the lowest pressure in the body so that the blood will keep flowing back to the heart. Velocities also change as we move through the system. So if we're looking at the aorta, for example, our velocities are going to be 100 or so centimeters per second. You compare that to, say, the posterior tibial artery down by the ankle when we're far away from the heart, and it's only, say, 40 centimeters per second. That velocity decrease has to happen. As the arteries branch out, we get into the smaller arteries and then the arterioles and the capillaries. The blood has to slow down in order for nutrient exchange to occur in the capillaries. So our bodies are intentionally designed to allow this to happen, and it's very amazing. And we see it while we're scanning as well. So normal velocity in the aorta is going to be higher than it is in the smaller vessels away from the heart. Blood vessels have 3 layers in the vessel wall. So the tunica interna, or the intima, as it's also known, is that inner lining that actually touches the blood. Then we have the tunica media, which is the muscular layer that will allow the vessel to expand and contract. And then we have the tunica externa, or the adventitia, that is the outer layer that touches the other surrounding tissue of the muscles and things like that. So the layers are represented in different amounts depending on the vessels we're looking at. So we might have more muscle in the ones that need to expand and contract more. We might have less muscle in, say, a vein where it needs to be kind of more fluid and adjustable. So vessels are very compliant. And what that means is that they're able to stretch and return to their normal shape, kind of like a rubber band. So they can expand and return to shape as long as nothing has happened to them. So this is just a video clip that's going to show you how that happens. And you can see the vessel expanding and returning to its normal size. And that is true arterial compliance. Every time our heart beats, the vessel stretches under that pressure, and then it returns back to its normal size. Large arteries are extremely compliant and have a very elastic component because they have a large volume of blood going through them. So every time the heart beats, they expand quite a bit. As we get into the smaller vessels, we don't quite see that stretching as much because the blood is kind of spread out, not quite as much pressure going through them. During diastole, when the heart relaxes, the arterial walls recoil back to their normal shape. But because they do that, we still have forward flow even when the heart is resting. So we have a little bit of flow moving forward at all times as the body needs it. There are some inertial energy losses as we go through the body, especially if we encounter a bend in the vessel. So here we have this carotid artery that's actually looping over itself. So it's doing an entire loop like a roller coaster. And what happens here is that we have velocity increases. You can see that there's color aliasing on either side here. But we'll get high velocities if we measure there. So we actually don't want to measure at vessel bends unless we truly believe there's pathology there. So if I were to take velocities in this vessel, I would probably do one here in this straight segment before we get to the bend, and then another one after we've exited the bend, but not anywhere that the flow is actually going around a loop, because then we get artifactually elevated velocities that could suggest to someone that there's a pathology when there really is not. All right, so velocity and stenosis. Velocity increases when moving through a stenosis. And if a mild stenosis might have a minimal effect. So we might not even really notice it, except that we can see that there's a little bit of plaque there. But not really a hugely detectable velocity increase. A severe stenosis, though, has a significant effect on velocity. And you can see that there's a pretty significant narrowing right here, and that is abnormal. So nice flow touching the vessel walls coming up to this area. And then again, we have that color aliasing, narrowed area. And as we exit the stenosis, the flow dilates out again. And this is post-stenotic turbulence that we're seeing with this color aliasing. So we see that on the color, and we can see it on our pulse wave Doppler as well. Now compare that with a dilated area. So velocity actually decreases when we go through an area of dilation. So for example, one place we commonly see this is at the carotid bulb. And it is normal to have a dilation there, but the blood slows down and it kind of swirls around. We get this eddy flow, and then it eventually moves forward again. In abnormal dilations, for example, an aneurysm, the flow in this area can slow to the point of stagnation, and then eventually we get thrombus formation in that area. So an aneurysm is an abnormal focal dilation. And if this is not the carotid bulb, for example, if this is the abdominal aorta, that dilation is not normal. All right, we talk a lot about resistance, and when we start describing waveforms, the resistance matters. But resistance is the ability of the vessel wall to oppose flow. So changes in vessel radius, so dilating and contracting, actually affect the resistance quite a bit. The vessel length and blood viscosity also have an effect on resistance, but radius is the most important thing. So there's something called resistance in series, and we see this in patients where they have multiple stenoses along the same blood vessel. So we have a narrowing here, and then a fairly normal segment, and then another narrowing, back to normal, another narrowing. So what happens here is it actually increases the resistance moving through the vessel. It's harder for the blood to keep moving. So we might get a big velocity increase here, but then we get to this next one, not as high of a velocity increase, and this third one, possibly even normal looking velocities, because we've lost a bunch of energy going through all these narrowings. So, but this patient is probably going to be having some symptoms. And when we have a patient with this diffuse type of disease and multiple narrowings, it actually has a more dramatic effect on flow than if that same patient had a single stenosis of the same length. So this patient with the multiple narrowings probably has worse symptoms than this patient that just has one long segment stenosis. Here's just a couple examples of what that might look like. So this left image is an angiogram of the heart. And what we're seeing is narrowing of the left anterior descending artery. So here's one, here's another one. So this patient is probably having some chest pain and symptoms with their heart. Here's another one that we would see on one of our studies. So serial stenosis of the SFA. We've got a narrowing here and then somewhat normal diameter, and then another narrowing there. So we can see all of this color aliasing, flow disturbance happening, and then back to somewhat normal flow right here. So again, this patient is probably having symptoms. And also, if any of you do ABIs in your studies, this patient's going to have an abnormal ABI if they don't have good collaterals. All right, speaking of collaterals, resistance in parallel actually decreases overall resistance. So let's say that this middle vessel is obstructed. It's got a significant stenosis. That by itself would have fairly high resistance to flow going through it. However, since we have these detours that blood can take around it, the resistance is decreased and the flow can move more easily downstream. So here's an example of what that might look like. Here is a short segment occlusion of the superficial femoral artery. And we've got a collateral, so a branch vessel coming off of here. And then we can see another one that's coming in to the vessel right here. So there are little tiny collateral channels bringing flow around that obstructed segment and providing an alternate route for blood flow. So we naturally have some of these already, but a lot of times they're not very robust. But once our body starts using them, they can get larger and even compensate for symptoms in some cases. And it is possible for some collaterals to develop over time through angiogenesis as well. So new little blood vessels and pathways growing if they need to. All right, so waveform analysis. We're going to see these things kind of come together in the analysis, and this is one of the most important parts of what we do. So I'm going to kind of lay a foundation here, and our other speakers will hopefully use some of these terms as we get through, and you'll kind of catch on as we get through the series. But my reference for these is this consensus statement that was released by the Society for Vascular Medicine and the Society for Vascular Ultrasound back in 2020. So I've provided a link to the article here, and there will be another one at the end. I really strongly encourage everyone to get to know this document and start using the terminology, because it really will help everyone get on the same page as far as interpretation of waveforms goes. So there are kind of general categories of flow descriptors that we use for arterial and venous flow. Number one is flow direction. We need to determine, is the flow going the right way or is it going backwards? So we'll describe that. Phasicity is another thing that matters. So more directly in the arteries, the venous flow pattern is also described, which will include phasicity, but there are some things that are more normal in different areas. And then arterial resistance that we just kind of talked about is also described in the waveforms, whereas in the veins, we describe more of the spontaneity, or is it basically not pulsatile. So arterial flow direction, here are the terms that we will use. So number one is antegrade. So this is forward flow. Flow is going in the normal direction we expect. And we will demonstrate that in the arteries as flow above baseline. So if flow is going backwards, we call that retrograde. And in the arteries, we want to show retrograde flow going below baseline, because then we are showing and trying to make it obvious that this flow is going the same way as the veins, and it is not normal. There's also bidirectional flow, where flow kind of goes forward and then backward and forward and backward. That's not the same as what we're seeing up here, where we have a little bit of a flow reversal. This is like very too much backwards flow, and suggests something is wrong. And then of course, absent flow, that means that we are not picking up any flow on Doppler, and that's not good. And these tables that are on here, they're kind of wordy, I know, but these are taken directly from that consensus document. So hopefully if you go back and look at it, they should look familiar to you. All right, phasicity was the next thing. And basically there's two ways of saying this. Flow in an artery is either multiphasic or monophasic. You might be familiar with terms like triphasic and biphasic, and the consensus is trying to go away from that to keep things simple. So we can see when we see multiphasic flow, we see it go forward and then it crosses this zero flow baseline. And then in some cases, it might come back forward again. This one below is just forward and then back, and then doesn't go forward again, but it's still multiphasic because it's crossing that baseline. Monophasic means that the waveform does not cross the zero flow baseline at any point. So monophasic also often connotates abnormal. So you want to be careful with using your descriptors. If you think in this case that this monophasic flow is supposed to be there, then you can still use it, but make sure that you're describing the resistance, which is the next piece. Okay, so high resistive means that this particular vessel doesn't need a lot of flow right now. So here we've got that multiphasic waveform, it's crossing the baseline. This is high resistive flow. In this case, this is forward, but no reversal but there's still no diastolic flow. So this is still high resistive flow because there is something that is kind of fighting back against the flow going through there. Intermediate resistive is sort of the next step where it's not really crossing the baseline. There's diastolic flow, but it's not a whole lot of diastolic flow. So this is normal in some vessels, such as a fasting superior mesenteric artery. We might see intermediate resistive flow. And then low resistive flow, we can see that the flow never crosses the baseline. We have forward flow throughout the cardiac cycle. So this is normal in some vessels, such as internal carotid arteries, renal arteries. Any vessel that is feeding something that needs constant blood flow should normally have low resistive flow. These waveforms down below are abnormally low resistive because you can see that it's kind of got a rounded peak here. And we'll talk about that a little bit, but low or high resistive can be normal or abnormal depending on the context. All right, so flow reversal is related to resistance in the distal arteriolar bed. So I mentioned before that the arterioles are the things that actually control what's happening as far as resistance goes. So here we have this flow reversal, right? So the greater the resistance, the greater the flow reversal. So this vessel is experiencing a lot of resistance because we've got that sharp peak here and a flow reversal. So if resistance is high, the reversal component increases in a normal situation. If resistance is low, such as here where we've got forward flow throughout the cardiac cycle, the reversal component may be decreased or absent. Okay, so let's practice describing these waveforms. So we'll do this first one here. So we need flow direction, we need phasicity, and we need the resistance, right? So let's think about this for a second. We're going to assume that because, even though we can't see the image, we're going to assume that because the systolic flow is presented above baseline, that these are antegrade waveforms. So both of these are going to be antegrade. Flow's going the right way. So this crosses the zero flow baseline, so it's multiphasic, and it's resistive. So something is keeping flow from going the rest of the way down throughout diastole. So this is a high resistive waveform. So this one, antegrade, multiphasic, high resistive flow. This one below is different. So still antegrade, right? But is it crossing the zero flow baseline? No, it's not. Also, we have forward flow throughout the cardiac cycle. So this is antegrade, monophasic, low resistive flow. Both of these are likely normal depending on the location and patient presentation. And I'll talk about why they're normal in a minute. So the things we look for a normal vessel: upstroke, peak, and lack of spectral broadening. So a rapid upstroke in an artery is normal. We want to see flow in systole from the beginning of systole to the peak of systole. That needs to happen quickly. So that's what we mean by a rapid upstroke. This should happen quick. Compared to this waveform, which shows a prolonged upstroke, it takes a while to get from the beginning of systole to the peak. So this slope is greater, and we can measure what's called acceleration time. How long is acceleration time taking here versus here? And they actually measured it. So this normal common femoral artery, the acceleration time was 90. This abnormal one, acceleration time was 200. So acceleration time is not always measured in the common femoral artery, but this demonstrates what abnormal looks like and how long it is taking. Okay, another thing we look at is the peak of the waveform. Normally, we want to see a sharp peak, like what we're seeing down here. This abnormal waveform that had the prolonged upstroke has kind of a rounded, a stretched out peak, right? So that is not normal. We want this nice sharp one down below. And then the last thing that tells us if something is normal or abnormal is lack of spectral broadening. So spectral broadening is filling underneath this window. So we want to see a nice white waveform. That tells us that all these red blood cells are moving in the same direction when it's white like that. And there's not a lot in this black area. So this is a good waveform. Down here below in this one, we are seeing a lot of spectral broadening. Though that spectral window is not black. It's full of white. So it could indicate that our settings are incorrect. Maybe our gain is turned up too high, our sample volume is too wide. We also see this using continuous wave instead of pulse wave Doppler. So we want to make sure our settings are adjusted properly. And then if it's still there, this is telling us that there's a lot of red blood cells moving in all these different velocities, and there's possibly some turbulence happening. All right, so normal flow profile changes, something that can change the way the blood is flowing, even in a normal patient. So here's an example, and the waveforms will change in a healthy vessel based on the metabolic activity of the organ it supplies. So for example, we scan a patient while they're fasting. They have not eaten anything, so their superior mesenteric artery shows a nice peak, little bit of a flow reversal, still some diastolic flow. So this is more of that sort of intermediate resistive flow pattern. But you don't need any nutrients go in there because we haven't eaten anything. Now the patient eats something, we've created a demand for flow to the gut, and that SMA needs to dilate to get more nutrients and oxygen to that area to help digest the food. So now we see the velocities increase. We still have that nice sharp rapid upstroke, sharp peak, but now a lot more diastolic flow because the vessel has dilated and allowed more flow to get there. So this is a normal case where physiologically the flow needs to change to help the patient digest their food. So here's another example. When we exercise, even just walking a little bit, but especially intense exercise, will change the way the blood is flowing. So here's a normal resting lower extremity artery. So we have sharp upstroke, sharp peak, flow reversal. Everything looks good for a resting vessel. So those muscles don't need a lot of flow while we're resting. So it just kind of sits there, and the arterioles in the leg are saying, no, we don't need that much, so it pushes back. Compare that to now the patient has exercised. So we had them walk on the treadmill, or they just ran in from the parking lot because they were late for their appointment. Now we still see a rapid upstroke, but a lot more diastolic flow. And that's because those muscles are demanding oxygen. And so the arterioles dilate and allow more flow to get there. Another case where this can happen is if your patient, say, has an infection or a wound in their leg, especially down towards the foot, the arterioles will dilate to help get more flow down there and try to help heal the situation. So in that case, it's not necessarily normal, but they may not actually have an obstruction of flow. It might be that they're trying to heal the inflammation or infection in their leg. All right, so this is just showing you flow through a stenosis. I kind of described this already. So we have flow going into the stenosis. It has to speed up through the narrowing, and then we get this turbulence coming out of the narrowed area, and we can see that on our images as well. So fairly normal flow coming up to it, increase in velocity, and then post-stenotic turbulence here. And this is kind of just walking through a stenosis. So before we get to a significant stenosis, we might see increased resistance. If it's a mild to moderate stenosis, we won't really notice any difference. But in this case, we've got a fairly significant one. So we still have rapid upstroke and a sharp peak, but you can see there's really no diastolic flow happening here. So increased resistance. So this would be a high resistive monophasic waveform. Within a stenosis, we get increased velocity. So you can see that this was below 100 centimeters per second, probably around 80 or so. And now within the stenosis, we're up to about 200 centimeters per second. So we're getting that increase in velocity. And depending on where exactly your sample volume is in that stenosis, you may catch some turbulence as well. So we're seeing spectral broadening, and even this kind of ragged appearance below is turbulence. Just outside of the stenosis, at the outlet of the stenosis, we still might be getting high velocities, but we're getting a lot more turbulence. So this kind of all this spiking above and below, that's all turbulence. So we still have a rapid upstroke, but now our peak is broadened out to all of this. So that's not normal. Then distal to the stenosis, we get more of a low resistive flow pattern. Velocities have decreased. Now we're closer to 60 centimeters per second, and our acceleration time is increased. So we've got more of a delayed sort of upstroke here, and monophasic flow. Okay, here's another example coming up to a significant stenosis or occlusion. This is more likely an occlusion. So we call this a staccato waveform. In this case, the blood is basically thumping up against a wall of an occlusion. So we get this really sharp looking waveform, and the blood doesn't really have anywhere else to go because it's hitting that wall of occlusion. Distal to a significant stenosis or occlusion, we get a dampened waveform. So again, delayed upstroke, rounded peak right here. And this used to be called a tardus parvis waveform. So we're trying to switch over to dampened now, but this is not normal. This suggests that we've got a significant obstruction more proximal to where we are scanning. So other abnormal flow, bidirectional, I kind of showed one of those earlier, but this can mean a few different things depending on where you are and what you're looking at. So in these particular waveforms, flow is being partially stolen from one area to supply blood to another. So it tries to go forward, but then it goes backwards and forward and backwards. So we have different vascular beds competing for the same flow. So this would be a case of a partial subclavian steal, if you've seen something like that. And we'll talk about that more later in another webinar. But same thing here, we've got a little bit of a flow reversal here and then forward flow. So this is a pre-steal type pattern. Pseudoaneurysms, if you put your sample volume in the neck of a pseudoaneurysm, you'll see forward and reverse flow because the flow has to go into the pseudo and then back out through the same channel. And another area, I'm not sure if anyone here is scanning endovascular aneurysm repairs, but some endo leaks will demonstrate that bidirectional flow pattern. So that's a leak outside of the repaired area into the aneurysm sac. So abnormal if we're seeing bidirectional flow. Here's another type of abnormal flow is when we have an AV fistula, arteriovenous fistula. So a fistula is a direct connection between an artery and a vein. It is abnormal if it's caused by trauma or if a patient was just born with it and they have a congenital anomaly. There are instances where fistulas are intentionally created for hemodialysis access, but in any case, the flow is very low resistive and turbulent and high velocity in those instances. All right, let's talk about veins really quick. So veins are the capacitance vessels of the body. They basically hold the majority of blood for us until we need it. And veins are really able to distend fairly large if we need them to. So you might be scanning an artery and vein next to each other and notice that the vein is often larger than the artery is. We also have paired veins in the forearms and the calves, which add to the ability of our veins to hold more blood. So you can see here just how much blood is being contained in each type of vessel. So the arteries contain about 30%, capillaries at any given time about 2%, and the veins have closer to 60% of our blood volume. Veins also have valves, and the job of these valves is to prevent retrograde movement of blood. So especially in the lower extremities, that blood is fighting against gravity to get back to the heart. So the valves help to keep blood flowing in the right direction. They are bicuspid valves. And as we move into the thorax and abdomen, most of the vessels there don't actually have valves. So much more common in the upper and lower extremities, and especially the lower extremities, like I said, because we're fighting more against gravity as we stand and walk around. Vein shape plays a large role in venous capacitance. So we can see in this case here, we have an elliptical shaped vein. So this has a lot more room to expand. This is the inferior vena cava next to the aorta. You can see the aorta is nice and round. The IVC is kind of teardrop shaped. So it actually has a lot more room where it can expand. Compare that to this common femoral vein, which is fairly round. It could probably still distend a little bit more, but quite a bit larger than the arteries next to it. Hydrostatic pressure has a great effect on our veins. So this is caused by the weight of a fluid as measured compared to a reference point. So we typically use the right atrium as the reference point, and then the blood density matters, gravity also matters. So hydrostatic pressure is different when we're lying down versus when we're standing. And then there's also the height of the column of blood. So the taller a person is, the greater their hydrostatic pressure will be, just because there's more volume of blood in that height of the column and greater distance for it to travel from the right atrium. So looking at these two people, I'm not sure how familiar everyone is with our American athletes, but this is Shaquille O'Neal and Simone Biles, and they are obviously very different heights. So whose hydrostatic pressure is higher? And the answer is Shaq. He is very tall. His right atrium is way up here, and his column of blood is very long. Compared to Simone, her right atrium is right about there, much shorter column of blood, so her hydrostatic pressure is going to be lower. So as I mentioned, when we're lying flat, hydrostatic pressure is fairly negligible. So we can use patient positioning to our advantage sometimes to make the veins look bigger and to help us see them better or to test for different things. So we'll talk about patient positioning for that tomorrow in the venous webinar. Also, one of the things that affects the veins is transmural pressure. So this is the difference between the pressure inside the vein and the tissue pushing on outside of the vein. If a vein has high transmural pressure, it is very rounded and more distended. A vein with low transmural pressure might have more of a dumbbell or teardrop shaped, and it looks more collapsed. So that means it has low pressure, and we can compress it very easily. So we need to be careful on that when we're examining them. Changes in vein shape are associated with large changes in venous volume. So again, distended, more volume, not distended, less volume in there. And position, again, can affect that. Respiration has another great effect on the veins. So as we breathe, we see the flow in the veins change, and we call this respirophasic flow, also known as phasic flow. And this happens because as the diaphragm moves when we breathe in and out, it changes the pressure in our chest cavity versus our abdominal cavity. And the change goes back and forth, and this actually helps keep the blood moving as we're breathing. So you can see in this particular vessel, when the patient exhales, there's less flow. When they inhale, there is an increase in flow. And this is opposite in the arms and legs. So let's do this comparison. This upper extremity vein, we have more flow when the patient inhales, less when they exhale. Compare that to the lower extremity, where when we exhale, flow increases. We inhale, the flow either stops or slows down. So this helps to keep the heart from getting overloaded with a bunch of flow all at one time, and also helps to keep the blood just moving nicely throughout both systems. The heart does have an effect on flow, especially when we're standing close to the heart. So we do see some pulsatility in the venous flow in the proximal upper extremity veins. So subclavians, brachiocephalics, internal jugulars can be fairly pulsatile. The proximal inferior vena cava and also the hepatic veins in the liver are fairly pulsatile, and that is normal in those vessels just because of their proximity to the heart. This lower waveform, though, is also pulsatile, but this is an abnormal venous waveform. So this can be seen in patients who are in heart failure or that have significant tricuspid regurgitation, because now there's too much flow getting backed up into the venous system, and we get this abnormally pulsatile waveform far away from the heart. If we have an obstruction, so this will be covered more tomorrow as well, but now we see there is no respirophasicity, there is no pulsatility, and that is because there is an obstruction somewhere between where we are scanning and the diaphragm and the heart. So any breathing we do can't affect what's happening because there's likely either some thrombus or a extrinsic compression of a vessel between us and the diaphragm. So we get what's called continuous flow here. So no respirophasicity, no pulsatility. It's just continuous and moving forward without any real fluctuations. Exercise is also important to note just because we do have a calf muscle pump. So this is why it's important for us to move around every once in a while to keep the blood flowing in our legs. But our calf muscles, as we move, as we walk, they contract and help push blood up through the veins and open those valves. So the valves will stop blood from falling back down as long as they're working properly. But every time those calf muscles contract, blood moves forward. So if the valves are not working properly, or if they're congenitally absent, we get what's called reflux. And the reflux is basically the blood falling back down towards the feet. So this waveform is showing an augmentation. So the sonographer squeezed the leg, and we'll talk more about that tomorrow, but they sent blood forward and then it fell back down. So this is abnormal. And we don't want to see reflux in our veins. Okay, so sorry, I had to rush through that last part a little bit to have time for questions, but here are the main references I used. I did get a few pictures from other places, and some were ones that I took myself. But I really encourage you to look at this consensus statement, and it has a lot of good information, way more than I shared in this talk. So, and I also want to thank Anne-Marie Kopinski. We use her textbook in a lot of our classes. And if you're looking for a textbook that's fairly comprehensive and easy to read, I really like that one. So I'm happy to take any questions.
Thank you, Leah. Thank you. Lisette, can you please stop the recording? Lisette, if you're there.
Yes, I will.
Thank you. You can stop it now while we take the questions.